Welcome everyone to the final day of the August START virtual orientation session hosted by the Center for START Services, a program at the University of New Hampshire's Institute on Disability, USED. All three sessions of the August series have focused on providing an overview of what START considers and why. On Wednesday, we learned about positive psychology and other foundations of the START model. Yesterday, we learned about the biopsychosocial approach. Today's session focuses on START crisis services. If you're interested in learning more about the composition of START teams, the roles and credentials of START team members, and the operational aspects of START programs, we encourage you to watch the START overview presentation on the CSS webpage. We will share a link in the chat. Today's session will have a 30-minute break at 3 p.m. Eastern, 12 p.m. Pacific, and conclude at 5 p.m. Eastern, 2 p.m. Pacific. You will be emailed a link to an evaluation at the conclusion of the day. We kindly ask that you take 5 minutes to share your feedback. We use this information to continuously improve. Today's presentation is a START Crisis Services overview. There is one case vignette that accompanies today's presentation. It is available to download from the webpage and was attached to the reminder emails you received yesterday and today. Please have this vignette on hand for today's breakout sessions. Before introducing today's presenters, I want to address a few housekeeping items regarding our use of Zoom features that will help maximize your engagement throughout the day. 2 general Zoom participation rules of thumb. Please mute yourself unless participating and keep your video off. These 2 things will help to ensure today's sessions run smoothly. Closed captioning is available during all plenary sessions and in a breakout session. In order to display closed captioning, please click the Closed Captioning CC button located on the bottom panel of your Zoom window. You can rename yourself by clicking on Participants, clicking the More button next to your name, and selecting Rename. Add a CC before your name. These instructions will help us to place you in the appropriate breakout room. Regarding breakout sessions, there will be 2 breakout sessions today, and you will be randomly assigned to a breakout room by CSS. Please begin your session by reading the vignette aloud. You can download the vignette from the event webpage. Please remember your room number and identify a lead speaker who will represent the breakout room's discussion if they're called on during plenary. When you're in breakout sessions, please turn your camera and microphone on if you're able. Active participation is encouraged. If you need assistance while you're in a breakout room, there's a button you can use to request help. You can use Zoom's chat feature today to share comments or questions about the material being presented. CSS will also use chat feature to share important information throughout the day. Please note that you can open the chat box to display as a side panel. A certificate of attendance with options to select the sessions you attended will be provided to all attendees. The certificate does include continuing education contact hours and is available for download on our webpage. You can also find the schedule and handouts on the same webpage. We'll post a link here in the chat and send in follow-up emails. And finally, there are members of the CSS support team that have help desk in their usernames. Please feel free to send them a chat at any point during today's session if you have questions. I'd now like to share some information about today's presenters. Dr. Joan Beasley is a Research Associate Professor, Director of the Center for START Services, and PI of the National Research Consortium on MH IDD. She holds a PhD in Social Policy from the Heller School at Brandeis University and a master's degree in Community Mental Health Counseling from Northeastern University. Dr. Beasley is the author of the START program, first implemented in 1988, and has worked to promote the development of effective services for people with disabilities and their families for more than 35 years. START was cited as a model in the 2002 U.S. Surgeon General's report on mental health disparities for persons with intellectual developmental disabilities, and in 2016, START was identified as best practice by the National Academy of Sciences Institute of Medicine. START is researched and peer-reviewed as an evidence-based practice. And Dave O'Neill is a project facilitator at the Center for START Services, as well as the director of IDD services at Sound Health in Washington State, overseeing a 40-person multidisciplinary team serving individuals in 3 counties. Dave has been a CSS project facilitator since 2012, supporting programs in Iowa, Texas, New York, and California. Dave also facilitates the Center for START Services MHIDD for Mobile Crisis Responders training course and the START Network Clinical Team Leader practice groups. He loves this work because he still learns something new every day. Welcome, Dr. Beasley and Dave.
Thank you, Beth. It's a pleasure to be back. Let me see what's wrong with my thing here. There we go. I will share my screen. I just want to welcome everybody on this lovely Friday morning, afternoon, depending on where you are. I'm going to think it's morning so that I'm a little bit younger, because I'll get some hours back in my day, and welcome you all back. Today, we're going to focus on crisis service, a crisis service overview. And we're really going to focus on the whys of what we do, not the hows and the whats. There will be some how and what, in that we will be talking about our cross-systems crisis plan. But we believe that effective service delivery requires that you really know why you're doing what you're doing, and that you really put a lot of thought into those whys. So I'm going to get going with my first slide. So first I want to welcome you on this, the 3rd day of our orientation. And I just want to remind you of a couple of things before we get started with the didactic presentation. First, no matter what we're doing, whether we're in a meeting, any kind of forum, visiting someone's home, a training, a crisis encounter, there are 3 elements that should always be expressed and communicated as part of that forum. The first is gratitude, the second is kindness, and the third is hope. And these are the underpinnings of what we try to do with START. Notice it doesn't say know everything, tell people what to do. It really says, let's be thankful that we all have the courage to be in the room together. Let's be kind to each other and respectful of our different positions and different ways of approaching things. And let's all work together to move things forward so that there's hope for the future. And I recommend that you consider these 3 pillars whenever you're doing any work, whether it's as a clinician, as an administrator. Gratitude, kindness, and hope are the 3 pillars that we try to foster in all our work at START. I want to recap the first 2 days before we get into crisis intervention by talking about START methods and humanism. So START is a humanistic approach, which means that it really encompasses an integrated understanding of the person as a whole. It's the whole person that is considered in the work that we do at START, and the whole person and the ecology around them, meaning all people that engage with the person, interact with the person, as well as the person themselves. And our focus in START is to really promote well-being, and this acronym PERMA: positive emotions, engagement, relationships, meaning, and accomplishment. And many of the people that we work with IDD do not have access to the opportunities that promote PERMA. And the last and least thing that we want to do in our interventions and support to people who have mental health conditions in IDD is do anything that undermines their opportunity to gain PERMA, because PERMA is really the emotional well-being that one needs to deal with the challenges in life, to have resilience. And through this focus on positive well-being and humanism, we do have hard science and we do use biomedical interventions, but we employ the practices of positive medicine. And please look these things up. They do exist. They are research-based. They're actually best practices in medicine is the focus on positive medicine, which is the promotion of health in addition to the treatment of illness, and being really cognizant of how to engage people in their own health and in promoting their own life journey in the world of healthcare. And that includes mental health. So positive medicine is a very important part of what we do in our biomedical elements of START. And then in our mental health interventions, we really focus, as you've heard quite a lot in the last 3 days, on positive psychology. Positive psychology and the promotion of PERMA and well-being doesn't mean that we don't use all the tools of the trade in psychology. For example, there's adaptations of CBT called positive CBT. And we really do believe that that positive approach, that pro-PERMA, pro-well-being approach, working with people's skills and abilities in terms of their character and the things that put them in flow meaning they're able to be like in the zone because they have the opportunity to do things that give them joy, is very, very important to the promotion of the psychological stability and actually psychological benefit of the work that we do. And the third is social. And one of the elements of positive and strength-based approaches is positive behavior support as a social construct. And positive behavior support is really using traditional behavior analytic theory and models, but really to promote the person's ability to learn new skills and to adapt using behavioral support interventions, but always understanding that it is about the person and the person's well-being and their sense of strength that we go forward. So positive behavior support does not sanction the use of aversives or negative reinforcement or punishment, because the philosophy is that anything that makes you feel bad or worse about yourself is really not something that's going to promote your well-being in the long run. So we promote positive behavior support. And really, we are a social work strength-based model that incorporates these biopsychosocial elements in the ecology in which the person resides. So we work in the person's system, in the system that supports them, in the wider system that supports those people, and so forth. And we are really a national movement, a national practice that really promotes well-being and positive approaches to addressing some of the terrible situations that people can sometimes be in. And as I address this when I talk about crisis intervention, it isn't that crisis issues are not scary, and it isn't that people don't have difficulty. It's about the way we see it and the way we approach it moving forward to help address it, understand it, and prevent it from happening again. So one final note from the last 3 days. I'd like to ask you to suspend your training and background in whatever field that you're in that you feel like you're an expert in. Sort of put that aside just for the next 4 hours. And please apply what we're presenting to you in your participation in the groups, in the sessions, so that you can experiment with perhaps a different way of thinking about something that you ordinarily approach one way. You might want to try looking at it another way. You know, the only way to continue to learn is to practice new things and to be open to new ideas. It is not meant to be an affront or a confrontation of your ideas, but it really is about being oriented to the START model to see if any of the ideas can resonate with your practice, or maybe expand your lens so that you can see a little bit more about what you might want to try in the future. So one of the things that we're trying to do here is build a community of practice, and we've been pretty successful. We're in 15 states in the US. More than 10,000 people are receiving START services across the country. We have very good outcomes. And it isn't that we all speak the same language or have the same voice or the same perspective, but we listen to each other and we employ this idea that gratitude, kindness, and hope are 3 elements that really help push us forward. So I ask you to sort of lean into that a little bit today as we talk about crisis intervention, as we give you the vignette. not about how you would ordinarily think about the person, but about how, in the way we're talking about it, how that might modify your thinking. One of the things that people have been talking about in the last 3 days in the chat room is they sometimes have to turn to more restrictive interventions because the things that they have tried have not been successful. Now that you're part of the START network, and those of you who will be part of START programs, you should know that there's a wealth of resources available to you so that you never feel like you're at the end of the line and that you're kind of stuck with being more restrictive than you would like to be because you no longer have the resources or options available. The idea is to open the doors to that, because really, once we become too restrictive, we fail to achieve our mission of promoting PERMA, which really doesn't allow the person to flourish. So we might eliminate temporarily challenges that we face, but it doesn't really promote the flourishing that we're talking about. So I ask you to think about it and suspend your thoughts a little bit and see how we'll go. I want to start by really capturing the representation in this room about your personal character strengths. So here is your first poll. Please take a moment and share, what is your top strength? Is it hope, love of learning, creativity, spirituality, love, prudence, humor, or kindness? Come on, everybody. Get that 35% of the people don't have a sense of their character strengths. Let's go, people. There you go. You can do it. Okay, thank you. So can you pull, can I see the distribution again, Beth? Thank you. So I just want to say that this is the community you're sitting with. You're hopeful, you love to learn, you're very creative, you're very spiritual. There's a lot of love in the room, lots of love. I think love is one of the highest ones. You're not very prudent, which, by the way, neither am I. We all have a great sense of humor, and we're kind. Kindness is the top character strength that has been reported by this group. So when you're in breakout sessions, just remember what a wealth of strength of character we have right here participating in this training. It's really fabulous, and I thank you all for participating. Okay, so how do I get rid of this? Okay, I close it like this. Okay. So here's a little review of what we'll be doing today. I'll be starting with crisis assessment and prevention for about 90 minutes. And then Dave will take over and he will start crisis intervention and then talk about crisis intervention, the second part of after the break. Dave and I are a little zippier than we are the zippy, zesty ones. The two of us are the how would you describe us, Dave?
I think you did it just fine. We're we're louder How
We're
about that?
louder. We're louder. So hopefully it's a Friday. We'll keep you into zippy zesty mode with our joy of the work. So here's another poll for you. So please respond to this poll. It's a question that people, IDD, access to most mental health services for people IDD happens at a time of crisis. So, and 85% of the time with START, what precipitates access to START is an event or several events associated with aggression. And I'm wondering why people who end up in mental health crisis services who have IDD have so much aggression. So please answer this poll now. So these are very good responses. I mean, most people understood that it's because of what we notice. So aggression is an externalized state, and it affects other people, and therefore they're more likely to get help at that time. But I want to talk about the other options as well. So I'm going to close the poll for myself and talk to you about this. While most of us did not vote that aggression is caused by IDD, oftentimes when you access traditional mobile crisis services, mental health services, as soon as people hear that the person has IDD, they attribute their aggression to their IDD, their developmental disability. And they don't really follow up with any kind of assessment at all. And that's one of the reasons why we have to do a lot of training, and why Dave's doing training, and we're all doing a lot more training. The understanding of cognitive disability and executive functioning does not really include an understanding that it isn't really having a cognitive disability and problems with your executive functioning which is causing the aggression. It's much more complicated than that. And so while we know that this is not true, it is often the case that people think it's true. And then what they want you to do is do things like tighten up on the behavior support plan before really understanding what the person is expressing through the aggression. Or adding more staffing is another one that often happens. There's big danger in this, in that aggression, externalized aggression, can easily become internalized aggression. And one of the things that is not well known in our community is the high rate of suicide in the IDD population that follows an event of aggression in which the person was sent home. And often the person does express despair and wanting to die and kill themselves. And because they have IDD, we're told that it's attention seeking or manipulative or just not true, basically. So internationally, a lot of data has been collected on this. The most common way that people die of suicide who have ID is through running in front of moving vehicles. And how many of us have seen individuals run in front of moving vehicles and thought that it was a learning need and didn't really determine whether or not this person was doing this with intent to harm themselves? So aggression is the externalized issue, but there's a lot of reasons why somebody might be have aggression, and it isn't necessarily caused by the IDD. And if any of you who work for mobile crisis teams would know that that is not exactly true, that only crisis teams want to be called after somebody has smashed several windows and beaten up 3 people. They actually would like to know when the person is emotionally dysregulated and having difficulty and you're worried about their mental health needs. Crisis teams do not need to be called only when there's aggression, yet often people wait a really long time before they ask for help. As somebody who was on call for 11 years for the First Start program, we would hear things like, you know, Johnny has broken 17 windows and I'm just getting sick of it, so you need to come now. Like, they didn't really think to ask for help, because in the DD world, people are taught that they have to be sort of a shock absorber for difficulty rather than asking for help, that it's a sign of weakness or a sign that they're not doing their job when they ask for help. And this lack of support for collaboration is a real issue. So it's one of the things we really work on with START, is really partnering with residential programs, with families, so that they know that there's no shame in asking for help and saying that you're worried. It is true that it's what we all notice. And one of the things that we teach people is something called vegetative signs and symptoms of difficulty. So what we need everybody to notice is when somebody's sleep has changed, when their mood has changed, when their level of activity has changed, when their appetite has changed, when their toileting body functions have changed, and other things as well. The things that they normally do have changed. And one of the people that I worked with, his processing changed. So even though he had ID, he was pretty responsive when you made requests. And when he was becoming psychotic, it took a long time. A lot of cognitive clouding occurred. And that cognitive clouding precipitated his aggression, which resulted in the crisis contact the first 2 or 3 times, way beforehand. And so what we learned to do was pay attention to his confusion as demonstrated by the way he interacted in his community around him, in his ecology. And by the way, there's a lot of talk about people with IDD not being able to tell you when they're having difficulty. People who are neurotypical, who are severely depressed, also don't tell you when they're having difficulty. Severe depression causes terrible cognitive clouding and slowness. And especially if the person's in deep despair, they will frequently not ask for help. So it isn't really about your developmental issues that people have trouble with communication. It's really a combination of your developmental issues and your mental health issues, or your mental health issues, even if you're neurotypical. So these are sort of like fallacies that come that really we need to kind of think about it. So one other thing, when you're monitoring how somebody's doing in the IDD world, we call this monitoring behavior. Behaviors are then translated as symptoms, right? Behaviors are translated as symptoms. When you're working in the mental health world, you're monitoring symptoms, and symptoms are observed as behaviors. So what on earth are we talking about? Interesting question. Why is it different? It's not really. So here I'm going to, there's going to be a lot of interaction today with you, because I think the best way to really process this information is by processing this information, learning by doing, the apprenticeship model. So I'm going to read this to you, and then we're going to break out into breakout sessions. This is a real case. Dave and I will both be talking about it, and I will tell you about what the outcomes were at the end of the case. Juan was recently discharged from an inpatient psychiatric unit, and I have to close this, and sent back to his residential program. He is being referred to START because of his long history of inpatient stays. His staff members are reportedly tired of dealing with his aggression, which we hear a lot, report that Juan is manipulative and attention-seeking. So they're pretty mad at Juan. Juan has GERD, asthma, and constipation, along with severe ID and ASD. He's also diagnosed with ODD. He's 23 years old. He enjoys helping to prepare meals and listening to music. Now, Juan has a severe ID and ASD, so he is nonverbal. I don't think I said that. If I did, I'm telling you again. Juan very meticulously folds his clothes or anything else he can find to fold. He loves to fold. I wish he could come here to my house. He sometimes cannot move on to another activity, so his folding has been limited in his behavior plan with a timer. So he's allowed to fold until the timer goes off, and then he's encouraged to go on to the next activity. Juan has been in his group home for 3 years, but they think he is not a good fit and would like to see him move. They state that Juan is a danger to the other residents, although there has never been an incident with other residents, and Juan and when they know it's coming, I don't know what that means. They're with other residents. This is a typo, sorry about that. So one of the things that happened with Juan is that he was exhausting for people to work with. He went to the inpatient unit. They modified a lot of his medications, and people were actually positively engaging with him. But they still worried that something terrible was going to happen, and they really didn't want him to stay there. So somebody needs to mute. For the discussion, how can we reframe the goals of engagement with the information presented here? So remember, I want you to take off your ordinary lens or hat, and I want you to put on the lens of a START clinician, biopsychosocial positive reframe. Now, it doesn't mean that your ordinary lens doesn't have positive reframe. I'm not accusing you of that. I'm just saying, please try to focus on the way that we approach it so that you can kind of get a sense of it. Think strengths, skills, and interests. What would you do when you came back to the meeting or thought about one? What are some of the things you might want to consider? This is the way you want to articulate it when you reframe at START. Not with a bunch of conclusions, but a bunch of questions. So if you can each come up with 3 or 4 questions, what would you ask yourself in order to have a better understanding, even a better understanding of whether or not he's a good fit for this group home? And we're going to break up now, and we have 15 minutes. So the most important thing that we need to know from this exercise is no matter how thorough the referral is, we may not have all the information. And everyone's perspective shifts from having a dialogue where more information is sought out. So the measure of our intelligence is our ability to change. And I didn't say this, the very brilliant Albert Einstein said this. So really, as a community to support people, our ability to change and think differently and ask questions and get different perspectives as a result of those questions and explore ideas is essential in good crisis prevention planning. And I'm going to just talk a little bit about effectiveness again, the 3 A's, from the perspective of, with respect to crisis support. So effective crisis support does encompass these 3 A's. And so through START, we think that the access issue is having a plan in place, knowing what your response time is going to be, and ease of getting the support you need, and the ability to get the resources you need within that support. So those are cornerstones of effective service delivery through START. Appropriateness is having training and expertise so that you can evaluate an individual with IDD-MH having a good, solid crisis plan, which is developed by the START team in collaboration with the person's team, having options available, and having the needs match the person and providing the tools for this to happen. So a crisis plan is written with the entire team, and Dave will talk to you in more detail about crisis plans. They're really a key to developing that capacity that we talked about on Wednesday, the ability for people to have a common understanding of what one presentation might mean and how to address it, how to get the help you need, and how to provide the appropriate support. And when I talk about expertise, I'm not talking about fancy clinicians coming into the room. I'm talking about expertise, capacity building, the family having expertise and understanding of autism in Juan's case, the direct support professionals having an understanding of Juan and expertise. All of us, the START team, having expertise. So really, appropriateness really requires an understanding and a common language that we can all address in looking at Juan. And accountability is really, really key. So in our case, accountability means we do in-person assessments, we have backup plans, we provide outreach, follow-up, and linkages. Accountability, responsiveness, engaging, flexible, and creative. So in our crisis prevention and intervention model for START, we try to address all 3 A's of effective service delivery for every single person in every single crisis event. So here's another poll. I want you to all pretend that you're a START coordinator. Some of you are and some of you are not. And I want you to intuitively think about what it is that you should be doing when you get a case referred to you like Juan. So here are your options. A, let people know that you have expertise in people like Juan and have a plan. You call them up and you just let them know that from the very beginning. B, since it's always medical, just tell them to deal with the medical conditions first and then get back to you. C, set up a time to meet with Juan and see him in his home. D, provide training about the medical conditions he has. E, set up an intake appointment and develop a provisional crisis plan. And the final choice is A and D, or none of the above. Well, that was musical.
I thought we needed some poll music.
Oh, was that you? Dave.
It's Friday.
Oy vey. I told you it was zesty. All righty. So you guys are really brilliant. One of the things that we often have to remind ourselves at START, I'm trying to get rid of the poll, as a START coordinator is really the first thing you need to do is meet the person before you even get the information on the intake, because sometimes, at least that's my style. Jill and Karen are out there somewhere. They might say you start the intake and you meet the person at the same time, which is fine too. But really, for me, my style is to really meet the person first and kind of get an impression of them, so that when I read the information in the intake form and I have them and I have the meeting with people, I can ask questions about what I observe. So some of the things that I might observe include somebody having an unusual gait or response, or looking pale or thin or sad or overly happy. And I'll ask questions about that to get a sense of whether or not people have noticed that and whether or not it's different from what the person ordinarily looks like. Also, somebody mentioned in the last poll that they were really curious about what things are like in his environment. It's really, really important to, especially if the residential program is having trouble, to see him in the residential program itself and get a sense of that. So the steps that an ordinary STAR coordinator would do would be to start with C and E simultaneously, and then probably look at those issues with the team, and then determine whether or not you have more questions, and then ask the 28 questions that you all have as part of that, and not come to any conclusion as to what you're going to do yet, because you really don't know what the problem definition is yet. And one of the big mistakes that we make, so we want to make sure that people know that we have confidence in training, but the last thing we want to do is be arrogant and presumptive that we have the answers and that the residential program doesn't have the answers. What we want to make sure is that we realize that we don't have the answers, we have a whole lot of questions, and that together as a team, engaging with the residential provider, we will find the answers together. Okay, here's another poll. You set up a regular meeting with his team to discuss how to best understand and support Juan. The time of the meeting is convenient for you, but does not allow for DSP engagement and Juan to be there. In order to address this issue, you, A, get detailed data on how Juan is doing, monitor his aggression carefully, and discuss at meetings. B, provide direct and clear instructions as to how to train DSPs. C, this is not a problem. DSPs are not part of the planning. D, schedule additional times to visit the program and get input from DSPs. E, reschedule meeting. Everyone should be represented, and you need to spend some time with Juan before or after each meeting. Both A and B, both C and D. Please make your choice. I think we finished with the poll? So the correct answer, of course, is E. Reschedule the meeting. Everyone should be represented, and you need to spend some time with Juan before or after each meeting. So while not all meetings need to include everyone at the same time, I mean, it's really hard to get everyone in the room together, even virtually. It's really important for the collective intelligence process and for asking questions and getting input to make sure that at least the first meeting, the intake meeting, when you begin to engage, that you include everyone in that has input and knowledge of Juan, and that you have the opportunity at the same time to see Juan, so that when they're talking about him, you get a sense of how he's doing today. It's really hard to do any work with a team to try to support them in supporting the person if you really don't have a sense of that person. And over time, you really need to see the person. So when you have meetings about people, you should include them in your visit. Now, do they have to sit through the meeting? No, they don't. And often people don't want to, and that's perfectly fine. What you do is inform them that you're here to meet with their team to help them get better services, and you ask them for their input if they're verbal, or you engage with them to see how they're doing if they're nonverbal. So you're absolutely right, 85% of you. Now, one of the things that we emphasize with START is the value of everybody in the person's life. And what we see that often occurs is that DSPs are not included in meetings. They don't have a voice, even though they're more likely to be the best informants to know what's going on with the person and how they're doing. I would especially choose a DSP that really likes Juan. So even though there's lots of conflict and stories about Juan, there's always somebody who says, I don't have any problem with Juan. I love working with him. And that's the person you want to talk to, because they give you this perspective that really helps you. And remember the collective intelligence study, which showed that people on various levels of power and ability and knowledge are collectively working together and having a voice really help to build capacity for everyone in the room at all levels. So this is the practice of START, and this is what we would do. And it looks like this is what most of you would do. The second choice that people chose, schedule additional times to visit the program and get input from DSPs, is something that I would have done in the past. And I would do going forward if I can't meet repeatedly with everyone in the room. But I would really try to begin with having everyone in the room at least the first couple of meetings, so that we all develop a common understanding. And also we get input. Especially DSPs are often the people who collect and report data. So having them understand the meaning of the data, having them have some knowledge of why we're collecting particular data helps to make sure that the data is actually collected in a more responsible and responsive way. Thank you. Okay, let's move to the next. So, Albert Einstein, if I had an hour to solve a problem and my life depended on the solution, I would spend the first 55 minutes determining the proper question to ask. For once I know the proper question, I could solve the problem in less than 5 minutes. So knowing the proper question to ask takes a series of questions and multiple perspectives. Einstein didn't come up with one question. That hour might have hundreds of questions in it. And then he finally figured out like sort of the target question to go forward today, and then the next question to ask to move forward tomorrow. And I think it's really important that you ask questions before coming up with solutions. And that's really the key to all of this. So when we have a mental health crisis assessment, the biggest issue that we have to determine is what is the presenting problem? What is the presenting problem that we're talking about here? When we're trying to prevent mental health crisis, we want to think about what might be the presenting problem. And there are many factors that bias clinicians, and some of those factors are thinking that I know people with autism and I know what often affects them, so I'm going to make certain assumptions. Or one has GERD, so it's obviously the GERD. Because the last client I had with autism and GERD, when they got gut pain, they became aggressive. So that's obviously the problem. Or it's obviously the problem that the person's residential program doesn't like them. Or it's obviously the problem that they don't have enough connection with family. So what usually happens is there is no obvious problem. The obvious problem is one isn't doing well. And then all of these factors that undermine his well-being from the perspective of PERMA need to kind of be sorted out. So what I like to do is use PERMA as a measure of my presenting problem and go through each one. Opportunities for positive emotions, opportunities for engagement, opportunities for relationships, opportunities for meaning in his day, opportunities for accomplishment. Does one have these? And then try to sort it out through asking a series of questions. There are many factors that impact diagnosis and treatment that we will go through in the next few minutes that actually both help to improve problem definition and can also undermine problem definition. The lens we use in evaluations matter. So if you are a podiatrist, everything is in your feet. You know, I I'm a mental health clinician. I was a family therapist. I also treated couples for many years. And one of the people came in to see me who was in a couple, and I had a private session with her. And she didn't have a history of depression, but she was very, very depressed. And and her worldview was very dark. She was very tired and lethargic. And I did not think that it was anything but clinical depression. And I did some therapy, referred her to a psychiatrist. Fortunately, the psychiatrist had her have a medical evaluation, and she had a thyroid condition. So my lens as a mental health clinician did not give me that multimodal perspective that I'm telling you to have today. Most of the things that I teach about are based on mistakes that I made or others made around me or with me. It's really easy to think that all behavior is communicating something you want or you don't want, if that's the lens you look at. It's really easy to think that all symptoms are a presentation of mental illness, if that's the lens you look at. It's really easy to think it's in your feet if you're a podiatrist, because that's the lens you look at. So understanding your own biases and pushing yourself to be more open in the way you ask questions and not jumping to conclusion is very, very important. And it even affects the kind of data you collect, if you're collecting data. And at start, we like to collect data because it kind of gives us a foundation for how people are doing in terms of their vegetated signs and symptoms. Are they sleeping? Are they eating? Are they engaging? What's their mood like? How are their body functions working? These things are very, very important, and monitoring them. So sometimes we'll find, like, if a person has a bad night's sleep, they're going to be more irritable, and there are certain things you need to do to accommodate them in order to avoid and prevent a crisis. And those are the kinds of pieces of information that we use to engage in a crisis plan. Then we have to figure out, well, why on earth isn't the person sleeping? So you don't stop with that. You go back and back and back so that you look at the layers of impact. And that is how we end up with a crisis plan and with an understanding of the person over several months period of time, as I said on Wednesday, that allow the person to really move forward in their life, pretty much preventing most crises from occurring in the future, even when under stressful conditions, because there's a multi-layered understanding of the presenting problem. So our principles that influence crisis assessment include some of the things that you really have to know about in order to make sure you're cautious about them. Steve Reese in 1982 wrote a very important paper on diagnostic overshadowing, and I'll go over that in a minute. Ann Hurley and Robert Sovner in 1986 wrote a very important paper about IDD and the influences of having IDD that affect mental health diagnosis and treatment. And Dr. Gardner did a really great evaluative paper on multimodal function, using the multimodal functional model. He was a behaviorist, but he believed in biopsychosocial measures, multimodal functional model, to understand aggression. And his work in aggression was very important to improving the understanding of what aggression is really telling us, and how you really can't either prescribe to treat aggression or write a behavior plan to treat aggression unless you understand what the aggression is telling you. So let's talk first about diagnostic overshadowing. Diagnostic overshadowing refers to the process by which a person with IDD receives inadequate or delayed treatment on account of the misattribution of their physical or mental health symptoms to their IDD. So I talked about this earlier. You get a call from the mental health crisis team. They get called, and there are problems associated with getting outside of the IDD, especially someone like Juan. He's nonverbal, he's autistic, he may present differently in the emergency room than a neurotypical emergency room patient, and they will not explore the symptomatology that they need to in order to ensure that they understand why one is dysregulated at this time due to diagnostic overshadowing. Now, diagnostic overshadowing occurs in many different worlds in health. So, one of the things that we all need to know in this world today is we have to manage our healthcare. All the efficiencies in the healthcare system create great opportunities for diagnostic overshadowing. And I'll give you the example of my dad as soon as I take a sip. Many years ago, my dad collapsed in an elevator. Actually, I was with Dave O'Neill in Washington State at the time, and my dad was living in New York. He collapsed in an elevator and was taken to the emergency room. My dad had recently had a heart attack and had stents in his heart. He was labeled a heart patient. And so he was evaluated for his heart condition. And they found that his heart, that he definitely was not doing well with regard to his heart. They treated his heart and they sent him home. They did no other evaluations. They just evaluated his heart because he was a heart patient. About a month later, my dad fainted again, and this time a medical evaluation was done, and it turned out that he had stage 4 colon cancer and was bleeding out internally. I don't know whether he would have lived longer had diagnostic overshadowing not happened, but it happens to all of us. You come in as a heart patient and suddenly nothing else is looked at, and especially if the emergency room is busy, especially if you're on Medicaid or Medicare and there's not a lot of compensation, especially if you're elderly. These are things that happen. And especially if you have a disability or cognitive impairment, they're more likely to occur. So diagnostic overshadowing has a great influence over the well-being of people with IDD who have mental health service needs, but also all of us anytime with any need. So I can give you like a ton of examples, and I'll bet you if I open this up to discussion, you could share examples of diagnostic overshadowing in your own lives. With COVID too. I mean, COVID is being diagnosed when other things are going on. It's really tricky, right? So we're all in the world of diagnostic overshadowing. Well, this has been going on for people with IDD for a really long time. So why worry? Because it's very common in mental health crisis services. And what happens with diagnostic overshadowing is we are most likely to simplify the complex. It's just a heart condition, or complicate the simple, forgetting the toothache, like look at his mouth, his face is swollen. Don't give him risperidone for a toothache. I mean, these are the things that happen, right? Attributed to what you know about the person, especially if they have IDD and they're on medication. So as soon as you know that about the person, you attribute their presentation to that knowledge. It overshadows the whole person approach to assessment. And we need to see the person instead of our biases about the person. We need to see what's going on instead of our assumptions. And one of the things that I try to encourage STAR coordinators to do is to sit in their car and leave their assumptions in their car. Like, put your bias in your glove compartment and walk out with fresh eyes, because our job as a START team is to offer those fresh eyes. It isn't to just regurgitate old assumptions or diagnostic overshadowing. It's to have a fresh perspective. And as Dr. McLaren said, and I said, and many of us have said, if you know one person with autism, you know one person who's autistic, do not make assumptions based on that, but we naturally go to that. It reminds me of, I don't know if this happened when you were naming your children, if you have children, but there are people in your life that you meet that you really don't like. Like, I don't know, I'm going to pick a name. this guy Irwin in the 10th grade, he was really annoying to me and made fun of me a lot. And so whenever I meet somebody named Irwin, I get this kind of face and I'm biased. It like overshadows my ability to see all Irwins. Having IDD is like being an Irwin in the world of mental health in some cases. They're like, oh, they've got IDD. I know IDD people. They're Irwins. And what I need to do is get Irwin out of the emergency room. And I really don't want to get involved with assessing this person. I just want you to know, in case you're wondering if I get feedback from my team about my examples, indeed I do. There will be Irwin jokes. I'm going to take it in stride. So I hope you're chuckling. Dr. Gardner, who was a wonderful mentor of ours, was somebody who sort of helped to bridge the gap between applied behavioral analysis and mental health treatment, and really helped to integrate those approaches and really put the ecology in which the person resides into his behavior analysis. So he really looked at things that set the stage, setting events, as being the social ecology in which the person resides, as well as their psychological vulnerabilities and precipitants as mental illness and biological and medical needs would be a precipitating factor that might contribute to an outcome. And his work was very, very important in the understanding of aggression. He spent most of his career reducing the use of chemical restraint, mechanical restraint, and seclusion for people in institutional settings, and also in helping with the deinstitutionalization movement. He was on John Kennedy's first committee on developmental disabilities back in the 60s and was a great leader in the field. And one of his key interests was the intersectionality between biopsychosocial factors and emotional well-being in people with IDD and the lack of understanding of those factors. I had the great honor of working with Dr. Gardner for many, many years. And he was a very close friend of mine and a real champion and mentor. And his work has really influenced our practices at START. So what has this got to do with crisis? And how do we apply it to our work at START? Well, one of the things that we do when we provide START services is START is not like a typical mobile crisis team. We're called a closed system. The reason that we're a closed system is that we really don't think we have much value in evaluating people just because they have IDD and challenging behavior, kind of loosey-goosey, like in the field. We think that training mobile crisis clinicians in mental health to do those kinds of assessments is just as valuable, and we should not silo mobile crisis response in mental health by segregating a team by calling them the IDD mobile crisis team. In START, we work with the people who are the most vulnerable and high frequency crisis service users and the people who have a long history of having a lot of instability in their lives. We're a closed system because we're not magicians, and we really feel like the best way to engage and make sure that we know what to do in a crisis is to spend a lot of time getting to know the person. Does it mean that we don't respond as soon as they're referred when we don't know much? Nope, we certainly do. But we do a lot to follow up and learn from every intervention and every event so that we can really explore and get into how to help that person and that system of support on a real meaningful level. The other thing is that a mental health diagnosis may take time. Although we have the DMID-2 and we have other tools to help diagnose people's mental health conditions, we really have a variant range and array of ability to psychiatrically diagnose people. And so the truth of the matter is that it really takes time to be accurate in a mental health diagnosis and not to be presumptive. And again, your biases get in the way. Like if you have worked with a lot of people with depression, you might assume most of the people you support are suffering from depression because depressive symptoms coincide with many other mental health conditions. People with schizophrenia can have very flat affect and be withdrawn, but their mind is playing tricks on them. And you may not explore that because you already are deciding that they suffer from depression. So taking time and exploring, lining up how the person presents, what the diagnostic criteria are, and then really collecting data, having conversations, observation, to really get a better sense of their mental health diagnosis. Crisis interventions provided with this kind of knowledge provide stability first and hope for the future. And that's really what our targeted aim is. So expertise on assessment is not the same as expertise about the person. So just going to a training on how to evaluate people with IDD-MH and knowing how to do an assessment is not the same as taking the time to know the person. So it's very, very important, especially with this high-risk group, to take the time to get to know the person and their system of support and the ecology in which they reside. I'm going to now turn to the 4 factors to be considered that were described by Dr. Sovner, who is our original medical director of START back in the 1980s and early 90s, and Dr. Ann Hurley, who is a psychologist who worked with our team and actually worked to help develop this Center for START Services at UNH until her retirement. So the first factor, and it was discussed in an earlier presentation this week, so I'm not going to really talk too much about psychosocial masking, but I'm going to get into what we think about at START when we consider psychosocial masking, which is limited social experiences influencing the content of psychiatric symptoms. Really, we ask ourselves, why? And why does it matter that they're less colorful? And that's because the expression of these symptoms may be missed or overlooked. Because when we look at people in the diagnostic, with diagnostic criteria, there's a qualitative change in their presentation, whereas with some of the people that we work with, it's more of a quantitative change, or the change is qualitative, but really, really subtle. So you need to know, first and foremost, what the person looks like when they're doing well. What the person looks like when they're doing well. Because for the example that I gave earlier of James, who becomes cognitively clouded, he has IDD, which can often result in delay response to questioning. If I didn't know that he had delayed response to questioning, that he ordinarily would respond much quicker, I would not have known what it meant for James that he took a long time to answer my questions. So they're less colorful, therefore less evident, and we really need to address that. And the third thing to really think about is cultural and linguistic competency and what to do when your dog is barking. There's nothing I can do, sorry. Cultural and linguistic competency will be covered in the next session. The one thing I want to make sure that everyone understands is that cultural and linguistic competency is something that we often overlook and undermines our ability to really look at the content of psychiatric symptoms in an individual. What is ordinary for them may not be ordinary for other people, and we need to kind of keep that in mind. The other area that Sovner and Hurley covered was cognitive disintegration. Why is it important? Because psychosis is not the same as panic. Psychosis is not the same as panic, but it could certainly look like that in some of the people we work with. They're not the same as attention-seeking behavior either, even though you get a lot of attention when you're in a panicked state. We need to understand the role of trauma, genetics, and stressors in a person's life in order to understand cognitive disintegration. If you suffer from post-traumatic stress disorder, cognitive disintegration is something that is frequent when triggered with a trauma response. So it's very, very important to know what the person's background is and to also know what the current stressors are. We don't pay enough attention to stress in people's lives with IDD. I think we think it's stress-free, but it isn't. And it's something to really keep in mind. And finally, there's baseline exaggeration, which is the quantitative rather than qualitative change in presentation that may be indicative of a mental illness. And it's more common in IDD, but not restricted to IDD. So baseline exaggeration, I'll give you an example. Baseline exaggeration from me. So I am on a behavior plan called Weight Watchers. I've been on it since like 1932 or something. And at baseline, I'm pretty good about eating, like a cookie on occasion, but not getting carried away. Like even when I get anxious, maybe I'll drink a glass of wine, maybe 4 times a week, something like that. Since COVID, my baseline exaggeration has gone wild. The bottles of wine are really going out there. I don't know if all of you are drinking a lot of wine, but there's a lot of wine consumption in my household. Baseline exaggeration. Is that sometimes a behavior that I have, like when I need a glass of wine after a stressful day? Sure it is. Would I drink that second glass of wine? Perhaps not. You need to know what a person is like when they're doing well in order to know what they look like when they're not doing well. You need to know whether on an ordinary day somebody might self-stim a little bit, but when they're self-stimming nonstop and can't do anything else but self-stim, that might mean something else is going on. Do not assume that more of the same is the same as usual. Do not assume that multiple glasses of wine is the same as 1 glass of wine a day. It's not the same. And remember, the people we support don't have access to wine to calm down their agitation in COVID. And they may not have 5 hats to wear at once to show you that they're feeling manic. They may not have the tools to demonstrate that they're really out there, So pay attention to small indications that even though the person ordinarily does this, they're really doing it in an extraordinary way. And that really is often an indication that a mental health issue is going on. It could be as simple as increased anxiety or as complex as psychosis. And finally, intellectual distortion, where symptoms can be masked by deficits in abstract thinking and expressive language. Now, again, Dr. McLaren talked about this. I would be talking to Robert about this now if he were alive today, because I think that our patients can describe their experiences and they can show us how they're doing, even non-verbally, but that we do not really bother to spend the time to get there. So for people who are verbal, the need for plain language engagement is key. And there are tricks that we use at START to make sure that people are answering the question in their own words and understand us so that we can really engage in dialogue with them. The other thing is that make sure you know what the person's primary language is and whether there are other choice ways of communicating. There are cultural and linguistic issues that are often get in the way of being able to get the person to express themselves. And the third is fear and stigma. There is so much fear and stigma associated with a person with IDD and their presentation that it's very hard to be open. It's very hard to be open to the fact that they really might need you and that you might have some resources available to help them. And the lack of time and listening can really undermine the person's ability to show you and describe their experiences because you're just not paying attention or you're just not observing. So again, as Karen said yesterday, we rely on data collection. It's what we do with the data, how we encourage people to engage. That's a little bit different, perhaps, than more traditional applied behavioral analysis. But lack of time and listening And lack of data, lack of understanding can really undermine the person's ability to express what's going on with them and to describe their experience, either through their actions or through their language or through answering our questions. So our job always is to provide, I ran over, Dave, I'm sorry.
Maybe if you could just keep clicking the slides, we can get through a little faster versus having to switch out, and then we'll just get to the.
All right, I'll click for you. But
Okay.
we're going to take a break soon, right, before the
Right,
break.
yeah.
So our job is to provide oxygen to the person and the people around them. And now let's all welcome Dave. I'm applauding you, Dave.
Nobody wants you to stop. You're on a roll here.
Go ahead, Dave.
All right. First thing we have coming up is a poll. So if you want to click to that, we can skip the other thing here. But and you know, I'm not going to say that Steve in the chat is ahead of the game here, but this is our poll. Beth, if we want to throw that poll up. I feel like the music should increase the polling, but maybe people are just dancing. The faster you vote, the faster this music will stop. Woo, okay. Wow, there's a lot of answers on here, but I mean, if you went with this, the start philosophy is it's a problem without the tools to address it. I like what Steve said, and a crisis is what happens when adults don't know what to do. But does that also mean that it's in the eyes of the beholder? Yeah, absolutely. Because only that beholder doesn't have the right tools, right? And then the lack of knowledge how to use the tools. You can have an amazing crisis plan, but if you don't know what it means, if you don't understand it, you're gonna struggle, right? You're not gonna be able to use those tools. Joni changing her own tire. She has a jack. She has a spare tire. Don't ask her to change the tire, right? She doesn't know how to use those tools. So, yeah, I mean, those people that added in the A and B, and then even through in C, I think all those are right. But we really want to look at it about first. Let's hope that they have the tools, and this is what we're going to move into when we start talking about the cross systems crisis plan. There was another slide up there somewhere, Joni. I thought you were going to keep clicking for me. Let's see. But now I can share because we only have a few minutes here. Let's see. Mm-hmm.
Thank God, because I stopped sharing by accident, Dave. I'm sorry.
That's all right. Well, I'm just hoping to get to a certain spot before we left here. So we love this quote. There cannot be a crisis this week. My schedule is already full. Crises are typically unplanned, although many of us who do crisis work might believe that there is a plan at 4:30 on Friday to have crises, because it sometimes may feel that way. But you know, I think one of the things that we need to remember about crises is that they are uncomfortable, not just inconvenient, but this is a situation in which no one is doing well, right? Everybody is upset. Everybody doesn't feel good about this situation. And it's this unpredictability of it is what makes it one of the things that makes crisis so inconvenient and so upsetting. Some of the planning process that we put into place might make things a little bit more predictable for us. It's subjective. This is in the eye of the beholder. There it is. It says in the eyes of the beholder right here on this slide. So I guess I can't, fault anybody for voting that. And, again, I think this idea about perception of crises, sometimes we have our own perception of crises as responders, as START coordinators, as systems people, that, they should be able to handle that, or, why didn't the police do something like this too? So it's not only in the eyes of the people who are experiencing it, but in the eyes of all of us. I think that we have to look at all of those biases and perceptions that move into things. I mean, typically, though, I do want to say when we talk about crises, we're talking about something that's either scary, that is stressful. It might be a dangerous situation. So again, we don't want to downplay anybody's feelings or their own subjective experiences. Okay, see, I wanted to get to this poll. I think this poll we'll take, and then we're gonna take our break. Mostly because I want to use this YouTube sound one more time. So if we can take this poll, for those of you on the phone, the residents' calls start on call at 8 p.m. I'm not saying it's a Friday, but it could have been, right? To report that Juan has been out of control. He is running around the house, screaming and opening and closing doors since early this morning. The on-call coordinator is tired after a long day, and it is raining outside. The on-call person does the following first. A, tells the residents to call the police, then calls admin on call to let them know. B, pulls up the crisis plan, sees where they are in the process, and calls admin on call. C, makes arrangements for an in-person visit the next day. Most of these situations can wait. Let start team know the next day. D, provide step-by-step instructions for staff over the phone. They clearly have no idea about what they are doing, and then calls the admin on call. E, over the phone, creates a safety plan, determines they can wait for arrival, then provides an in-person or video evaluation, and then calls the admin on call to discuss prior to the arrival. That is our poll. Perfect timing on that finish there, Beth. All right, some kind of two main answers here, right? I appreciate the pulls up the crisis plan and sees where they are in the process. That assumes that we have a crisis plan. That assumes that they know about the crisis plan and that they've heard of it. They know what we're following. We have a good plan that is well written, and we want to see where they are. That is an important step. There are things around how you build up to crises and what you are looking at through our crisis plan that allows you to kind of understand some of the setting events. So it's not a bad answer. We prefer the bottom one, the one that got 68% of the votes. That over the phone, we create a safety plan. It doesn't sound like there's anything dangerous right here. This opening and closing, and is someone's going to get their finger slammed? Is he going to hurt himself? Is he planning to run out in the rain and catch a cold? I'm not exactly sure, but we would figure this out and try and figure out how do they feel safe. Provide some oxygen to the person who clearly, again, in the eye of the beholder, is stressed out over this. This is a scary thing. They're upset. They're tired. They have some fatigue here. It does sounds like nothing's too dangerous. They can wait for us to come. We're going to go ahead and go out and see if we can see what's going on. We're going to talk a little bit more about why that is, and then we're going to, of course, check in with our supervisor, the admin on call, to make sure that things are that all of the information is up to date. Have we gone through our logical step process? Was there anything we may have missed? And again, this collective intelligence about all of us being able to learn from each other and have new input is very important. So thank you for that. What we're going to start with when we come back, and this will get you back right at 12:30, is Joni's going to tell us the story of Juan. So we're going to have a little bit more after the break. That's something for you to look forward to.
So Juan is a true case. His name wasn't Juan, but it's a true story. And so a lot of the questions that you had were things that we really addressed in getting to know Juan. Oh, by the way, somebody mentioned in the chat room that the way the description of Juan was written was very negative focused. That's usually the way we hear about people. So I described exactly what I heard. I would never describe somebody as manipulative and attention seeking, but that was what was reported. And I wanted to give you the profile that was given to me. I was the person. This was back in the day when I was the roving START coordinator in a northeastern state that some of you are on this in this training are members of, and this was my case. And so I was asked to. So I worked with the team, and the team was wonderful, including the behavior. We called them. The behaviorist, that's what we called the person who wrote the behavior support plan. And a lot of the things that people talked about were really addressed. One being that they needed to figure out what else Juan was good at and what he enjoyed doing. He was in the hospital for about 30 days in the neuropsych unit at UMass Medical Center. He was on a lot of medication. And by the way, more is not better with medication. You can actually be very irritable on a lot of meds. It makes you feel lousy. So his medication was reduced. Dr. Charlot's team has a behavior analyst on it at the time, and they worked with the behaviorist in this program. They came up with a better plan. I think he still had the bell, but he also had other options to occupy his day. He had music time. He could make a choice with regard to the activities that he participated in. He had more of them. There was a few other things that we were able to do. His medications were reduced, so he was more alert and less irritable. And the other thing that was really interesting about Juan was he did have a lot of natural support. His family loves him very much, but they would just sort of pop in and visit with him, like sometimes every day, sometimes once a week, very erratic. And Juan would get very happy when he saw them and very sad when they left, which the staff really resented, and Juan didn't really care for it. So one of the things that was negotiated was a more predictable schedule, not so rigid that the family couldn't just be his family, but not so loose that people weren't able to prepare Juan for their arrival and their visit and prepare him for their departure and staying back at the home. So he was doing relatively well. He was discharged from the hospital. The staff was skeptical, however, that this was just sort of a fantasy that we were all in with this new plan. It was working pretty well, and then one day the things just sort of blew up, and he was running around the house. And honestly, I was at a loss. Like, I went in, the behaviorist went in, the clinical psychologist from the state was there, the direct support staff were there, like the team was definitely there, the parents were there. We saw Juan. He was calm but very tired. So we're sitting at the kitchen table at this group home, and we're all like scratching our heads. And the maintenance guy was there too. He wasn't in the team meeting, but he was fixing something. And he goes, excuse me, I was just wondering, do you think it was the lights? So it turned out that when Juan was in the hospital, a staff person had twisted their ankle while going into the back door of the house at shift change time, because it was dark. It was 11 o'clock at night. So they put on those automatic lights, and the lights were very bright, and nobody noticed that it was shining right in where Juan's face would be in his bed, because he wasn't in his bed because he was in the hospital. So that what happened was at 11 o'clock, the lights shone in his face. He freaked out. He was abruptly woken up. He ran around the house, opening and closing things, trying to like figure out what on earth was going on. He would calm down and rest, go back to bed. The shift change happened again. The lights went on because people left at like 6 a.m. It was still dark. It was wintertime. On with the lights, out again. And by then he was out for the day, just running around agitated. So it was not something we would have predicted ever, ever, ever. And it wasn't in our biopsychosocial plan, look for lights. But one of the things that I then put in every assessment was changes in the environment, the physical environment, like not just the community environment, the people environment, but the physical environment. So we figured this out. we put on room darkening shades in his room, took a couple of days, he settled down, and then things got quiet. And actually, he had very few crises. He had a few a year, but he was having, 16 events a month. So he went from like constantly in crisis and in despair to maybe 2 or 3 a year. And usually it was around things like changes in his routine, or he wasn't feeling well. And the staff were much better about it. And they, now I'm sure he's still living with them today. And, there's probably been staff turnover, but it would probably be unimaginable to send Juan out of the house now. I mean, he is a member of their community, and they probably love him because he's a very lovable guy. So that's the story of Juan. What do you think, Dave? Unmute.
When you're sharing a screen, that moves to the top of the screen. It's no longer at the bottom, right? I can't find. Yes, I think it highlighted much of what we've already talked about, right? I mean, even in the midst of all our question asking, we still can come up with wrong answers. We still need everybody's perspective. We still, the idea that you would get the answer from the maintenance guy. My guess is that even in all of our planning, we never invited him to the meeting.
Right. Oh, somebody asked, what was the aggression? He was a thrower. He threw stuff. He never went and punched you, but he had he indiscriminately threw things. Like he would clear a table or slam like empty cabinets, like cans, which isn't really safe. So people were very unsafe. They felt very unsafe. He unintentionally hit a staff person a couple of times with an object. It wasn't intentional, but he became so dysregulated that he just kind of threw things around. Sorry about that. That was his aggression.
No, I mean, I think that plays right into this. When you look at components of what is a crisis experience, some of the precipitating events that you talked about with Juan would be maybe that, staff were tired, right? That he was exhausting. He had all these other plans. He's had inpatient hospitalizations. But we spent a lot of time talking about vulnerabilities, that exercise and the amount of questions that came from the people exploring his case was wonderful, both around executive functioning issues, like we heard over the last couple of days, the biopsychosocial factors that influence presentation. I mean, people were bringing up like, vision and hearing, which came up, in past, people were bringing up polypharmacy and medication side effects that, that Dr. McLaren talked about. I mean, the presenting problem is often described as an incident, right? They look at this as this one sort of thing, which doesn't give any further explanation, doesn't give any needed information. We've got to explore these kind of things. So, I mean, these underlying vulnerabilities that result in crisis are part of this whole assessment process and part of what we need to do when we go into planning. And that's what it's those kind of things that increase the likelihood of whether it be a mental health symptom or whether it be, some sort of challenging crisis, experience. When a new trigger is present or when stress gets presented, right? So, I mean, I think Joni brought this up, but lack of sleep in all of us, we aren't really at our best. I don't know how many of you have experienced grief, but if you've had a recent loss in your life, when you bring up COVID, I just had a team meeting at the little break here with my team, and to continue to remind people about health and wellness. That's important, and when those things aren't taken care of, we're just not at our best. Why am I having trouble moving this forward?
And you on this list of yours, Dave, you have the word recovery, and I think recovery is not the same as a cure. Recovery is recovering from the trauma of having a mental illness that is not well treated or understood. It doesn't mean that you don't have that vulnerability. It's recovering from the extended difficulties associated with having that vulnerability. So Juan was always going to be Juan. He was going to have these issues, but the understanding of him and humanizing his experience allowed him to experience true recovery.
Yeah, thanks. Because I think mental health those of us who have a mental health background are seeing this recovery as this absence of illness that is there. And what we're trying to do is this promotion of positive, right? This promotion of understanding. And so it is a different language, and speaking the same language is important. So thanks for that, Joni. And I mean that, it's important to look at how the principles of START relate to everything we do. Joni talked much more about this, and it, so we won't have to spend too much time on it. But are there opportunities for PERMA in the middle of crises? Well, there is when you're trying to assess it. Are you going to get permanent crises? Some people say no, but when you think about understanding positive emotion, how are you going to interact with the individual? When you think about relationships, achievement, when someone has a successful disposition, you see PERMA in the system, you see PERMA in the individual when you're able to come to a meaningful and understood disposition around a crisis situation. Joni had those 3 words at the very beginning: gratitude, kindness, and hope. Walking into a crisis situation with those things it can be difficult. I mean, maybe you can show some kindness, right? And hope might be good. You think you're going to get out of this, although you may not know what you've gotten into yet. But gratitude, we are blessed with the opportunity to be trusted to see people at their worst, and that may be the systems, that may be a provider, that may be the individual, but to be thankful to be allowed in and to be able to be trusted to make these decisions and to help to explore this more, I think is that's how we're going to move forward and be more positive in how we deal with systems. There's terrible terminology about like high utilizers or frequent flyers. That taints the way people see them. That taints the way that they're treated. I would tell you that they're probably not treated with a positive psychology overview. So being able to think about how we're walking into these situations, and are they set up for strengths, skills, interests, needs, activities, those kind of things. We always ask when the person was at their best. That's part of the assessment process. And the reason for that is this positive psychology principle. So we have explored that a lot. So move on to the next slide. Trauma-informed crisis intervention. So Jill talked about a bit about this yesterday, that people with IDD do experience trauma at higher rates. And depending on when that happened, certainly in childhood, we see a lot of brain chemistry changes, how that increases the risk of mental health conditions, which then increases the risk of emergency service interfaces. So, oftentimes crisis feels like a conflict cycle, right? Something has happened and then this conflict cycle. Trauma-informed care looks at things like conflict cycles, looks at things like coerciveness, right? So how are we trying to get somebody, or how are we trying to get an individual's problem solved? There was some info in the chat about restrictive options. Anytime we hear about safety or physical restraints that come around safety, we know that safety is important, but this least restrictive option is, we have to consider potential triggers before we engage people. And I think some of the ways we can do that is, the trauma-informed principle is not just that I know trauma, right? I know trauma exists. That's one of the big pieces, is just the recognition of why trauma happens. Now, that's great for ongoing care and treatment, but in the middle of a crisis, you may not care how it happened. You just need to feel safe. It doesn't prevent that crisis, knowing that trauma may have caused it, but it does give you tips in how you might relate to that person. Comfort and support is something that helps with trauma. And I've seen a lot of emergency room plans where individuals with IDD are punished for being in the emergency room. They're not given comfort measures. They're saying, because this person likes the emergency room, right? Well, maybe they like the emergency room because they're getting some of this comfort and support. I'm not saying you have to give them a 5-course meal, but I see things like, don't offer them food, don't give them a pillow, don't do these things because they like it and you're trying to reinforce this. It's really not very trauma informed. We're looking at promoting relationships. We're looking at respect. We're looking at keeping an individual informed about what's going on, no matter what their verbal skills might be. That's also calming to whoever else is involved in the crisis, trying to stay connected to those individuals and to keep hope. That's what trauma-informed means in crisis intervention. So, I mean, we're going to kind of go through these different pieces, so I won't spend tons of time on any of them, but we want to, we have a cross-systems crisis plan, which we're going to go into next. The actual crisis event and crisis state, the call for help, what I want to point out that people sometimes forget is we assume that the people want your help. And also remember that anyone calling you is in crisis. Oftentimes the individual may not be calling us themselves, but somebody else that's calling is also experiencing that crisis. They're also heightened. So that first piece around the O2, the oxygen, giving someone oxygen, it addresses the distress. That's a nice little mnemonic reminder, rhyming tool, right? Address distress. Let people know that help is on the way. And that provides them a bit of oxygen. They know that somebody's going to help here. I'm not alone. And that's huge. And that's, Joni has some great stories about it. And I've experienced many too, where, you just have to tamp that down a bit. You don't know what's going on yet, but if you can give them something, then that's going to give them that resilience to kind of get through until the next step. So then how do you address that? And it follows up like this. We're going to roll through some of this. So planning, I think there was a slide that Joni put up that said, if you want to teach people a new way of thinking, give them a tool. Because I don't know if she used it in this one, but if you try to teach somebody something, they may not necessarily let it stick. But if you give them a tool and you work with them on that tool so that they understand how to use it, it leads to new ways of thinking. When a START person first meets an individual, they do a provisional crisis plan. Now, sometimes that's not much more than providing the oxygen. It's maybe giving them the crisis line number so that they can call and check in with somebody. And even if you could write a great crisis plan, it's not going to be that great the first day you meet somebody. But it starts to foster that dialogue around hope and what can we do. This is, again, part of how the ongoing discussion is. Already, okay, when you're meeting someone, they may not be necessarily in crisis, although they probably had some distress to get START involved. But the idea is that they probably also deal with things on a regular basis, this primary intervention strategy. So what does their ordinary day look like? Because this person probably has anxieties or stressors or things that happen every day, and they get through every day or most days, right? Crises aren't necessarily happening that often. So they're able to find, what is this primary intervention? How are we able to figure these kind of things out? You start having that discussion, and that provides support. It provides focus again on positive, and it gives us a place to start. So getting there is you're, like I said, you're not going to write this at the beginning. It takes time and a lot of collaboration. So we have a START tool called the Cross Systems Crisis Prevention and Intervention Plan. And I asked, who is the author? Well, the author
is me.
Joni is the author, as far as like she's really good at asking questions, which go in boxes. But to fill in those boxes, the author of the Cross Systems Plan is in the title. It's the systems, right? So there was a lot
That's what people think, right? Who is the author? It is me. But is it?
Right.
I didn't mean it was me, Dave. I'm trying to help you here. We're trying to help you.
Oh, okay.
Right.
All right. It has gone through iterations, but yeah, I have seen people who have presented me with a cross systems crisis plan that they wrote based on their collateral data, because they thought that was I got this from the doctor, I got this from the ABA provider, and I got this plan from the school. Nobody had a discussion, and Joni talked a lot about fostering dialogue and how helpful that is. When you ask questions together, when you have a conversation together, it improves that collective intelligence. It brings common understanding. Maybe you would even invite the maintenance guy. I don't know. But when you start figuring out this this mutual definition of a goal. So sometimes somebody might say, oh, well, he has a diagnosis of bipolar. And then a question might be, well, what does bipolar look like in him? Well, what is mania? And how else could that be manifested? And I mean, I participated in the groups just like the rest of you. We don't know each other. These are very small bits of information we're getting about people. And we're starting already to reframe these and ask these questions and change how we think about individuals. You don't get that from just pulling collateral information from a variety of other crisis plans and making a new plan, right? So, I mean, everyone writes this together. It's a systemic intervention and it's owned by the system. People are much more likely to follow it or believe in it if they've had a part in it. So getting each of those voices is really important. And Joni talked about, does that mean you reschedule? Yeah, because if the DSP who's going to have to actually use this crisis intervention plan hasn't talked about what they see and how they interpret this, and maybe actions that they had reported at the psychiatric visit that none of us heard because the DSP is the one who took them to that visit, right? So all those information we'll build that conversation and be able to write a much more important plan and one that's helpful. I thought there was another slide in here somewhere, but did I miss one? No, okay. So this is what's in the plan. I'm assuming people on this call many of the people on this call will have START programs that are opening soon, or that have already opened, or that you're a part of a START team or part of a START network. You will be invited to one of these meetings. So you will see this form, you will be asked these questions, you'll be having the same sort of dialogue that we're having now. So if you are in touch with any START program or any individual that might be enrolled in START, you can count on being invited to one of these. The form is pretty long, and people can be off-putting, right? We've already seen, I already have a 17-page positive behavior support plan that I didn't read. Now you want me to make another form here? So when they see this form, the uninitiated to the cross systems plan say, why is this so long? I just want to know what to do when he does this, right? This is the crisis plan I want. No, it isn't what they want, right? So why do we have these things on here? Demographic information kind of fits into like what is the environment which he lives in. We've talked about how important context is, how important environment is. In the last case, people were asking about Juan's friends, about his family, about his cultural communication skills, right? All that stuff gets wrapped into the demographics, and you can see now when we have that, how important it is. When we think mental health and health. Oh.
So do you want to know why they're in there, Dave?
Why? Who's in there?
Why it's all in there? It's in there because it was really meant for networking purposes, so that the mobile crisis team could get access to the crisis plan, and they may not know Juan that well, or if you brought him to the emergency room, or if he was hospitalized. So on the inpatient unit, even on inpatient units, people go into crisis, and they're actually more prone to go into crisis. So we try to give a lot of information about Juan's ordinary life and general patterns of behavior, strengths, skills, and interests. It doesn't assume that the residential person doesn't know, but it does assume that not everyone knows. And it also is supposed to be followable, even if you're like a relief staff person. And I know nobody else has staff turnover but the people of Seattle, but there are a lot of places where that might have staff turnover, so a comprehensive plan is needed.
Yeah, and that's for this information and all this information.
Yes.
More specifically, I mean, why we have different pieces of this in, because people again say, oh, it's too long. Why this? Why this? Mental health and health diagnoses. There was some examples yesterday that seeing what's on there is really important. I use that example. So someone puts down ADHD. They say, oh, he has ADHD. That's informative, because what do you think people have been seeing that led them to an ADHD diagnosis, right? I'm not saying I agree or disagree with that diagnosis. That's what he has. But how do you think they were treated with that diagnosis? How do you think, I think I don't remember if it was Jill or Karen that brought up something like borderline personality diagnosis, right? How do you think people with that diagnosis are treated? What kind of things were being exhibited or signs and symptoms that were noticed that led people to think of that diagnosis? Those are very important when you're trying to kind of have that general consensus and conversation. So that's one of the reasons we put it on there. Some people say, well, I put it down there because that's what he had on his psychiatric list that I got. Well, let's have a discussion about that. Health diagnoses are also important because we've talked a lot about, again, the biological components and the medical issues that are going on. Sometimes people don't have those health diagnoses listed, and where you'll find it is in their med list, right? If all of a sudden they have a med list for, Prilosec, then you might know that they probably had GERD at some point, right? So then you can ask those questions. Oh, well, he has Prilosec. Is that given for any particular reason? Right? And then that starts to bring out some of those. You can see how this conversation is sort of what goes on. The strengths, skills, and interest and general patterns of behavior. This is, again, why are we looking at strengths? What do they look like? What do they look like when they're doing well? This is historical info about this person in a variety of different contexts. There's a lot of different questions that sort of pull this out about what they like when they do well, things that they find stressful. Dan, at the very first one, mentioned the idea of tracking positive, like when do these things not occur? And there's questions in here that pull that out. How have they dealt with this in the past, right? And these kind of conversations start leading us down to our intervention sections. So yeah, there's, like I said, there's lots of other plans out there, but I haven't seen a mental health crisis plan. I haven't seen a positive behavior support plan that pulls all this stuff together like the cross systems crisis plan does. And again, if it's just another form, forget it. If this is not put together without cross systems collaboration, or having that conversation, it's not going to be worth the paper it's written on. We say talk. This isn't, the goal of this plan is to avoid more intense, more severe services. It goes through primary, secondary, and tertiary levels of intervention and levels of care, and different triggers or vulnerabilities that might lead to those things. The real hope is that you're able to start from a thorough understanding of this conversation. It's promoted communication has stopped us at these earlier levels. Will we get there? Yeah. But when you do get to those spots, that's when it's not a failure necessarily of any one person. It may be a failure of the plan. We want to revise it. A good plan changes over time. You want to talk, you don't know everything maybe in that first meeting. You haven't learned some things. I think somebody yesterday said that, I think in talking about crisis, one of the chat things was like, they say, I don't know what's going on. Well, this is a spot where we start to form these hypotheses, not necessarily in the crisis moment. We're actually able to start planning. So when I said things are predictable, crises tend to be unpredictable, we can start to put some potential predictions around things as you're starting to have these conversations. You can form these hypotheses, then they get tested out through an actual event. And if it's wrong, we learn from it. If we, when we know better, we do better. So start plans or start coordinators. This is what emergency on-call reports look like. It's important that you remember this is a closed system. This isn't operating for everybody in the mental health system. It's not everybody in the IDD system. It's people who are designated on a START team. And one of the essential roles of START coordinators are to assist in the evaluation when there's an emergent need. So that's why we have these 24/7 coverage of on-call and fully operational teams. Why 24/7? Because, like I said, sometimes it's not planned, but it may seem planned for 4:30 on a Friday, right? A significant number of calls do come, after 5 o'clock or on the weekends. And, there's a lot of reasons for that in what kind of other supports are available, what kind of programming is going on. That's when PERMA and their regular day schedule has been forgotten. There's a lot of reasons why it's important to be available during that time. Telephone access is immediate. I do a lot of, I think it was mentioned in the intro that I train mobile crisis teams. Mobile crisis teams don't usually like you to call them, right? They usually go through a call center, which then screens it and then calls the mobile crisis person, who then calls you back within a certain length of time. That can be pretty frustrating for people who themselves are experiencing crisis, and who knows what's happening in the situation for them, right? So this goes right to someone who can help. That is different from, like I said, many systems. And then the in-person response, which right now with COVID, some of that's been telehealth based and video response, is within 1 to 2 hours. And it also, another difference is that is going to also be wherever the person might be. A lot of mobile crisis teams are required to respond either with police, wherever that might be, or at an emergency room, emergency department. Part of also the in-person response and the immediate telephone access is because we want people to call when they're worried about something. If you're having to call the police right after you call us, you waited too long. So we want to, I see you leaning, Joni. I'm watching you out of my corner of my eye.
I see can I just pop in with a little chat question? Just very quickly.
Oh, yeah.
So is there a way to link someone that may be in need of these services coming through crisis services? Yes. So we didn't really talk about sources of referral, but somebody can be using mobile mental health crisis services as long as they're eligible. The START team in your community can get the referral from mobile crisis. They could even talk to them on call. They just won't be able to come out and evaluate because they don't know the client, and they will follow them. So if they're admitted or gone home, they will do the intake. They'll take the referral and do the intake in a timely fashion and enroll them in START. I just wanted to answer that question. Thank you.
Right. And it may be answered, but yeah, get it out of the way now. So, because otherwise it might get buried. Thank you. Because I'm not watching that chat right now. The stabilizing the current environment is important. That's why I want to continue to bring this up about where you go, where the person might be. Emergency departments are not nice places to be, really. It's very serious when you get to emergency department or a hospital. So if you can stabilize someone in their current environment by going out in person, and whether that be providing oxygen to the care providers, or whether that be, assessing what may be needed for the individual, this is one of our core philosophies, thinking back to that nice little wheel that Joni put up, was apprenticeship and coaching. That can only be done if you're with somebody, right? That capacity is built if you're operating within the system of care here. So that this gets back to some of more of that cross systems work. When you're doing in person, you're with the people, and there's something to be said for why that improves things. And like Joni said, the next day follow-up, that is so valuable, because many times people are a disposition happens or a recommendation happens, and then nobody follows up on it. Nobody's able to say, where is this going? How am I going to get help in the future? People are much more resilient when they know that there's going to be some follow-up, and that may be in the form of a START intake. That may be in the form, if they're already a START enrolled client, that may be a next day visit. But these follow-ups are key. We do a morning triage every day that reviews any calls that may have come in the night, or anybody that we may be worried about, which enables us to give that follow-up in a prompt manner. And we have found that increased outreach and finding out what people are worried about decreases crisis calls. I don't want to give that secret out to make anyone go out of business, but crisis calls go down when this happens. There was a study that I think I'll reference later too, but Joan, who's on the National Research Consortium for START, did a study on emergency department use in individuals with IDD over a 2-year period in Ontario. They found that 1 in 2 adults with IDD went to the emergency department within that 2-year period. That's a big number. She hasn't duplicated it. I think that was done in like 2011, 12, something like that. But that's a lot of people going to the emergency room. And so, just you attending this orientation, I think gives you some tools to go out and teach others and talk to others about, what might be going on that can I think stems some of that. Yeah, I could go on about that. So again, part of that is enhancing the existing crisis supports. There is likely before START comes to your community, or even once START is in your community, there is already existing crisis supports. You may have a mobile mental health crisis team. You may have a co-responder thing. You may have a CIT team with the police department. I worked a lot with Iowa. Iowa's mental health emergency system was the police. We had to do a lot of work with educating the police about what does that mean, and why does, where are they transporting, and how do we, they were very interested in how we might decrease some of those phone calls. Right? So this linkage in partnerships, which I believe was also on the wheel. See how this all ties together, right? The linkage in partnerships with who? So when you're a crisis provider, or when you're thinking about from the crisis support lens, linkage in partnerships might be with the police. They're going to be with the providers for sure, because they need to understand what is acute. When do I need to call who? They need to be with emergency department social workers. Emergency department social workers only see people with IDD in some sort of emergency setting. So again, the eye of the beholder that we talked about at the beginning, this is what they think IDD is. So that bias is already there. They also, I don't know how many of you have worked in emergency departments, but when you ask somebody in the emergency department, yes, I'd like a medical evaluation. Oh, I know that the reason on your presenting symptom is aggression towards staff, but yes, I'm asking you to do a medical eval, right? That's hard to do, and many of them are not very interested in doing that. They would like to turn that bed over and get the person discharged, right? Having a relationship and a partnership and involving them in the cross-system planning makes that a lot easier, right? So, yeah, I mean, I just think that those linkage and partnerships are key. They're also, something that many of you on this call will be responsible. You're working with other partners. You're working with current systems. So making sure on how this will work together. START does not replace any system. I think that's been said maybe once in this training, but that's really important to understand here, that we're not taking the place of the ongoing emergency mental health system. We're enhancing it with the expertise we have and with the cross-systems crisis planning process that we do to help and increase the capacity of the emergency system to manage people with intellectual and developmental disabilities. And it really does extend to outside of the people that work with START, because you do this with some person that works with START, they're going to hopefully use this on the next person with IDD that comes through their door.
Dave, there was another question that came through the chat.
I'm sorry, I'm not looking at the chat. Let me get my chat music on, though. I have some chat music.
No, Dave. Don't put your music on. Listen to Beth.
Okay.
While you're queuing it up, Dave, has START observed a large percentage of individuals misdiagnosed both from a mental health and a health standpoint, leading to medications being prescribed that the person should not be taking? And the follow-up to that was, what about those who suspect anxiety, whereas there could be a true heart condition?
Yeah. This is why we have that conversation that we had earlier. The answer to the first question is a resounding yes. But now, how you tease out that the specificities of that second question, that is, again, the more people who bring their ideas to the table, the more likely you're going to get to the right answers, right? Or you're going to at least ask enough questions that you're starting to get to that solution. That question specifically was around, are you able to detect a heart condition when you're thinking there's anxiety? Hopefully, right? And hopefully some of the things you see with the heart condition, right? You get the physiological symptoms of anxiety. You might also have the physiological components of, a stroke, a heart attack, whatever that might be. So age, weight, and you always think medical first. I'll talk about this again later, but I'll give you that sneak preview that many people who end up in the emergency room have medical conditions. So thinking of those medical conditions first, especially at that tertiary care level, because something's gone wrong to get them that far, right?
So we've had people come to the resource centers in several states One person I remember that I worked with Jill Hinton with had a heart attack at the resource center, like right after they arrived. We had somebody who had a stroke, and the stroke was not diagnosed until they came to the resource center. So yes, it is a problem. And part of it is debriefing with the teams and reminding them that they really need to do these medical assessments, and talking to the hospital that hasn't cleared the person properly. But my own father wasn't cleared properly. So it's an ongoing struggle. Absolutely.
Right. We had a similar issue where one of our individuals was using a lot of drugs and alcohol, and they attributed all of his slurred speech and poor gait and things like that to drugs and alcohol use, and he had also had a stroke. Yeah, and that was identified by the START coordinator, but it took forever to get the rest of the system to accept that likely happened and that we were seeing some after effects and to get him treated. So why was my START coordinator able to notice that? Because he showed up, right? In the time of COVID right now, many things have gone to where, showing up is not really an option. Somebody yesterday said in the chat, or maybe it was in one of the groups, it's really hard to tell without talking to the person. Well, that's true. And we've been put in a situation now where maybe you're just giving information through a social work informant. And I don't think that's good enough. One of the things we've done in Seattle is passed out to hospitals that didn't have the technology or weren't willing to use the technology. They have iPads to allow us to interview and examine the person visually. I think that's, why seeing the person is important. And I understand we're in the middle of COVID and that this is a hard thing to hear, but it may take some, adaptability or can you describe what it is you're looking for in the person, right? Can you ask them to talk about gait? Can you ask them to talk about...
You videotape it on the phone.
Yes. Can they videotape it and send it to you? There's somebody just brought that up about seizures the other day or something. I think that was a way that was done. So there are ways for you to do this, but it is a key element and something that we strongly encourage if, in some new adaptable way, right? And then this is typically what you do. You examine the person, you look at the complaint, what's the history. For us, we're going to be able to look at the cross systems crisis plan that we have for the person. We're going to do a mental status exam. We're going to ask for medical and physical assessments, knowing that people with IDD have medical concerns that often are underlying some of what is challenging individuals and systems. And again, nowhere in there am I saying, come up with the answer. Nowhere in there am I saying, tell them what services are needed, right? This is all about full evaluation before we get to that step. We're not making a determination of what needs to get done. We're listening and we're observing. Oh, we have a little breakout session. And unfortunately, breakout session music has also been discouraged. But so here you are about to go out on a crisis call. I'm curious about what are things that get in your way at the time of crisis? What are you worried about when you have to think about going out to conduct a crisis assessment? And don't everybody say COVID, but I mean, you can say that. But what are the things that concern you about addressing this? And why are we having a training around crisis services? Why are we training mobile crisis providers throughout the nation around what's in our way? I think maybe we'll move on right now. I think
Got it.
I think that, a lot of those are some of the things, those fears, that unknown, and that encompasses a lot of the things that we discussed there. Although Kenia has a list of another 5 if we want. No, I really appreciate that. And hopefully we covered some of those things. But I mean, knowing that you're not alone, that these are scary situations, and that even Joni, who's done this for 30 years, still doesn't walk in thinking she's going to go with her Joni checklist that's going to work every time, right? You're going to observe and you're going to notice.
No, and when as you're sharing your screen, I can say this. If you're afraid and you're a new START coordinator, or the situation seems scary to you, don't go in alone. Your admin on call can go in with you. So as a start team, we work as a team, and we always, always have the courage to say, we feel nervous or we're not sure. And we ask, and it's okay to ask for help. It's actually very wise to ask for help.
Yes. So again, you're walking into this, you're doing your assessment, you're having an interview. We've talked about the importance of meeting with the individuals. There's also collateral information, but one of, again, making this go full circle, the cultural competence piece. In the Dr. Lunsky study that she had about the 1 in 2 individuals with IDD who are going to the emergency room, they did this via, knowing who the IDD individuals were and then reviewing all the records that were in the emergency room. In those records, it was like 45% had no mention that the person had an intellectual or developmental disability. To me, that's a cultural competence issue, right? You're not even considering, it wasn't even mentioned what that might do. We talked about executive functioning and the full array of that. And to not be able to understand what that may or may not look like, or what the developmental overlay onto how they are communicating medical symptoms, or what mental health symptoms might look like. Jody mentioned that every mental health, symptom is also behavior in everybody. So, developmentally it might look a little different, but it's still, something to be noticed, and to be able to pull that culture piece out of that. And then you throw in something like the case of Juan, where you have not only the developmental disability, but you may have, other cultures or other languages or different communications and different understandings of what emergency departments do or don't do. So cultural competence is setting out on this adventure, which you don't know what it's going to be like. The bias, crisis impedes your ability to think clearly. And again, I think that's where I really liked what Kenia said. We get that feeling. We have our own biases about what I'm walking into, or maybe this is a residence you've been to before, or maybe this is an emergency room that didn't treat you as partnership-like as you had before. How are you processing and thinking clearly to be able to put that in the car and walk in, with the positive, trauma-informed, culturally competent, care that you're going to deliver in this assessment? Some of that requires you to use plain language. This is because some terminology, we have a lot of acronyms in this world that we work in, and some mental health acronyms and some IDD acronyms have some similarities but are very different. So, when you're talking with the system, I think, language that is understood by all, talking in the same language, but really in talking to the individual, using plain language, even if they're nonverbal, building up that positive regard, that respect, that rapport that you can still build just by having a conversation with somebody. I think that's super important. And when you talk about plain language, that's around, there's other things that come with language, like the modulation of your voice, the way you speak, the tone in which you use. I saw an individual who had said something like, don't talk to me like a baby, right? There's tone is very important, in the language that you use does impact how people feel when they're receiving, a crisis service, when they're already in a bit of, chaos anyway. Time to process is really important. We've talked about communication in general, and I think I said just a few minutes ago that crisis impedes everyone's ability to process, everyone's ability to think clearly. My wife was in a car accident, and they asked her phone number, and she couldn't remember it. And she is a very smart woman. She's an accounting controller, doing all that. She couldn't come up with it. And with given time to process, she was able to kind of calm herself and be able to pull that out. Individuals we work with have barriers and executive functioning issues based on sometimes whatever their intellectual and developmental disability etiology is, but that is important in a crisis situation, and especially when you have somebody who has some cognitive impairment. That's also important with the providers. That's who we talked about them being under stress. We talked about using an informant, but when an informant isn't able to think about everything because they've just experienced a crisis, you've got to give them some time to answer in their own way. I put voice in quotes because, again, that time to process may not lend to verbal communication as easily, but it does lend to observation of like nonverbal things. Dr. McLaren actually really went over it well, I think, when she talked about, motor activity and facial activity and social emotional distress. What does angry or withdrawn look like? Or is there some moaning happening? Is it, there's a way that answers are being given. Communication is always happening. We just have to pay attention to it. So making sure that you're having that time with the individual and allowing them to answer in their own voice. Now, are you going to need to get third-party information? Probably. There's going to be people you need to connect to. There's going to be people who, are able to give that to. But making sure you at least give that time. Make people comfortable and build rapport, tied into some of the positive stuff we talked about earlier. But this is also, the family, the caregivers, the individual. These are important things, especially like Joni said, the reason 99% of these things don't turn south is because of these kind of considerations, right? When people are more comfortable and then they believe that you're there to help and rapport is there and you're not, spiraling up the situation a little bit more with some of this, conflict or coercive type things, which might trigger some traumas. That's going to really, really move this interview in the right direction. Dr. Beasley, did you have something to add?
Yeah, so the chat room is a very interesting place.
That's why I don't look at it when I'm
I'm challenged, Dave, to be mature. But so the question was, what do you do when the family or the provider are the problem, when they're agitated, when they're making things worse? And I think you answered that question, and maybe if we perhaps all listened to carefully, we would hear the answer, which is we have to have empathy. People are dysregulated, they're traumatized, and they're not their best selves. So we never identify people as problems. They present with difficulties, but we try to engage them and be respectful and as supportive as we can be. And that often helps to neutralize the situation. Really, the job of a good crisis intervention is to stabilize the situation and provide hope for the future. It isn't to change people's personalities, identify the dynamics in the system, cure the common cold. It's to stabilize the situation and come up with a plan for hope and moving forward. I feel a little bit challenged by some of our participants today that we are not being specific enough or prescriptive enough. And the whole day we're talking about, we don't think you should be prescriptive. We don't think you should be prescriptive. We think you should be exploratory. So the mission of today's talk is about exploration, about providing respectful engagement and exploration so that eventually the system together can become prescriptive and effective. And so I will end my speech with that, Dave. You can move on. Thank you.
Well, and I'll probably go through these next ones kind of quickly because I think I do want to get to answering a little bit about what you're talking about, I think, when we get with like recommendations and disposition type things, because I think that's where people want to go with the crises. Believe me, I've trained a lot of mobile crisis providers now, and they all want the answer, right? And it's really, again, teaching people how to think about how we're going to get to that answer. That Einstein quote keeps coming to mind, which honestly, the first time I'd ever heard it, I didn't really get it. But the more I've worked in this, the more and more it makes sense, right? I guess that's why he's smart, but the key thing that we're looking for here is change. Somebody is having an ordinary day, something happened. I had a recent case, a 51-year-old male. He had been supported by this residential agency for 11 years. He had had this period of increased aggression and assaultive behavior where he was hitting staff and wandering into people's rooms and just seemed really out of it. And they wanted to give notice on him. What we had noticed is that He had had some changes in his medications. He had used to have a neurologist, and he was having an increase in seizure activity. Understanding what those changes are in the context of those changes is what we're looking for. Asking the questions shifts our perspective. Any change that happens with somebody is dysregulating. So, when those changes happen, you need to figure out why. I often hear this thing, well, if we could only just give him some coping skills. And then I want to ask, coping with what, right? What is he having to cope with here? Because then you're starting to get to the actual answer, right? We do a lot of, I think, expecting the changes and skill building to happen in the person with intellectual and developmental disabilities, and not in us as a system in how we think and respond to that person. Who is this person? We've talked a lot about character strengths, and so, I'm not going to go into that a lot more, but, so what is the problem? Again, much like if you were in the group and you came up with, I don't know what I'm doing, it's because we don't know what the problem is. Someone also asked that question about, is the diagnosis right or wrong? Well, it's often different. It's often aggression. We see what that looks like. This is why we ask to describe what happened and in what context versus sort of them just telling us. Asking that question to describe it a little bit more. I think in one of the earlier answers, somebody said, what does aggression look like? Because this is from a study by Dr. Charlo, one of our START consultants. And I present this just because, problem definition requires collaboration. It requires context. It requires history. It requires information. People with IDD sometimes will present with the similar behavioral repertoire. So you really have to be exploratory, using Joni's word that she would like. That's the word of the day. Here is aggression caused by constipation. Here is aggression caused by extrapyramidal symptoms, some sort of med side effect, and sedation. Can be caused by gastro reflux. If they're depressed, there's mental health conditions that can be causing this. If their friends are agitated, right? If they're bored, there's all of this can still present the same. So if we're not looking at context, history, and information, whether that be in our cross systems crisis plan that we've found historically that cause some of these issues, or whether that be questions that we're asking either of the individual. Sometimes the individual will tell you, right? But I think this is a key slide when we're talking about a presenting problem. And that presenting problem tends to be something that we can't really define. I think another Dr. Charlo quote is, aggression is like a fever. If you go and you say you have a fever, sure, I can take a Tylenol for that, right? But that's not necessarily going to ever get to the underlying problem of my brain tumor, right? Okay. If only there was a tool where we could figure out and ask informative questions about the biopsychosocial. Oh, well, START has that tool. It's called the Recent Stressors Questionnaire. Paying attention to stress. Joni, you used my line that I like to use earlier, which is that for some reason we downplay the effects of stress on individuals. She talked about the cognitive disintegration that happens in everybody. And guess what? I have found that no meds have ever helped a stressful and unhappy life. So I know that's often an answer that people are looking for, and it's often what you will get if you get an inpatient hospitalization stay, but it is not addressing these issues. This incident that led to the crisis has stressors. This is not restricted to people with IDD. This tool that we use, why we use it is because it brings up, I brought up my wife couldn't remember her own phone number. Do you think that someone's going to remember that there was a change in routine? Do you think they're going to remember that they noticed this symptomology change, that they noticed that a med was changed a couple of weeks ago? Or you have to ask questions. And this is just a guide that we use to help ask through those biopsychosocial questions, because attention to stress, stress reactions and acute reactions to stress are one of the main reasons that people visit the emergency room. That was found in both Dr. Charlo's information and in Dr. Linsky's. So why are we adding crisis response services to existing systems that already have crisis response services? And I think this is because of it's the training that the staff, the START group will have, and you all have at least had an orientation to it now as to why we do the things we do. There'll be much further trainings on what those things are, but being able to understand the developmental considerations in a biopsychosocial model that are typical to the person that you figure out through your planning process gives you the ability to really notice and monitor and interpret the signs that we're seeing appropriately. It's that appropriateness of understanding the signs and symptoms that we're seeing and how to get that information both out of the individual and out of the system that lead us to a much better resolution. This is just a little graph that we have. Any of you who have some of our manuals might have seen something like this. It gives an emergency assessment process. It's pretty self-explanatory, so I'm not going to go into it since you're going to be able to get this off of your off of the PowerPoint that I'm sure you were all downloading, with 5 minutes left before 5 o'clock for you East Coasters. But it kind of goes through some of the initial contact, how the disposition plan is developed, and what we'll do for follow along. But I think, I had another slide before that. Beth,
I cut it. Go
on.
on.
Did you? My recommendation and disposition slide?
Yeah, get it out. No.
That was the one that was going to talk to them about some of the things that they were bringing up. Like,
Yeah, but we're not answering them now.
Right, we're not answering them, but what I wanted to put on there, so I had this really great slide that Joni thought was done, right? But it was a list of questions like, what is the individual communicating? What's the current presentation? What are the person's treatment needs? What is the best place to address these needs? I wanted to first note that it was a list of questions. It wasn't a list of conclusions, right? So it wasn't telling you what to do. It was saying, did we ask the right questions? I mean, the best place to address their needs, is that really going to be in a hospital setting? I don't know how many of us have visited in-person hospitalization, in-person units. They're not very pleasant. I don't enjoy it. This is the accountability person. Joni's giving me the time, but I wanted to say we have to do a best practice around the individual where they're getting assessed appropriately and matched to the relevant level of support or care. We have to do it at the caregiver level. So we know caregiver fatigue is real, especially in COVID. We have to understand the capacity of the family system of the providers and give them enough supports and tools. And we have to do it at a systems level, which is the follow-up piece where interagency communication and interdisciplinary conversation is key and important. And I mean, we talk about care coordination. Well, it needs to be coordinated. Those are the best practices.
And we also have to give the person strategies for coping themselves, right?
Yes, under the individual, yeah.
Yeah.
Giving them the relevant level of support and care, which is
next slide. It's the most important slide.
It really was. It really brought it all home. But
the next slide.
Next slide. Never in the history of calming down has anyone ever calmed down after being told to calm down. If you haven't heard that story, that comes this gets brought out every time I tell Joni to calm down. Never works. Let's see. Also, we want to tell you, I don't know if I'm supposed to say this or if Beth is.
Beth, you can do it.
All right. Please save the date for September 15th. We are going to have virtual orientation sessions in the months of September and October. This slide is talking about the September sessions. Going forward, the first day of each of the sessions will be open to everybody. Anyone who's interested in attending can register to attend. On September 15th, we will have a day-long keynote on cultural and linguistic competency with Tuara Good, who is the director of the National Center for Cultural Competence at Georgetown University and a close colleague of the Center for START Services. The second 2 days are for START team members only, so there'll be different registrations for that. September 16th will focus on training methods used by the Center for START Services and START programs, and then September 17th will focus on evidence-informed practices. Next slide, please. Oh, this is fun. I never get to say that.
Oh, that's me. Okay. I was trying to catch him on the chat. Right. Okay.
In October, the same thing. October 27th is open to everyone. That day will be focused on the trauma-informed care and the application of trauma-informed care. We have a keynote speaker, Dr. Karen Harvey, joining us, as well as CSS's clinical director, Dr. Jill Hinton, and our director of therapeutic supports, Ann LaForce. Second 2 days are start teams only. October 28th will focus on working with families and systems linkages, and October 29th will be about putting it all into practice, as well as a viewing of the START film that was just released. Next slide. This slide gives an overview of our annual training calendar. I had made some comments to some of you who were talking about the need for training for mobile crisis responders. The Center for START Services does offer a training course on the mental health aspects of IDD that is offered quarterly, and you can find more information about that course and a course coming soon for care coordinators and case managers on our website. And I've posted the link below, and I'll put it in the chat too. Thanks, Dave.
Yes, that was it. All right. Thank you very much, everybody who hung in.
We really appreciate it. And look at how big Dave's head is and how tiny mine is. Like, that's
someone in the chat wrote posture. I don't know if that was my posture or the posture walking into a crisis situation, but I was wondering if I should have,
Anyway, we really, really appreciate you all hanging in there with us.